Welcome to the Epilepsy Foundation's Hangout on Patient Safety in the Epilepsy Monitoring Unit. This is a joint project of the Epilepsy Foundation and the American Epilepsy Society for the Epilepsy.com professional section. This will be an educational discussion for professionals involved in epilepsy care, or for people who refer patients to an epilepsy center, or for those who are caring for people prior to, during, or after epilepsy monitoring unit stays. We know that patient safety has been an increasing concern probably since the early 2000s, when the Institute of Medicine highlighted the critical problems with patient safety in their publication called To Err is Human. In this Institute of Medicine report, 6 national aims for quality of care were identified, and all of these are so important for patient safety in a monitoring unit. These include the safety of the person within a hospital setting, the effectiveness of care, the efficiency of how we provide care, the timeliness of care. Is it provided at the right time for the right patient? Is it equitable care? Is everyone getting the same thing? And is it patient-centered? Is the person you're treating and their family at the center of your care decisions and what you are doing to help them? Care in a hospital setting is also monitored by the Joint Commission for the Accreditation of Hospitals. And this organization has established safety goals each year, and the ones that address people with epilepsy are present in all of these patient safety goals. A few of them that have been very critical over the past few years include identifying risks within your hospital setting, identify groups of people or populations of people who may be at high risk for injury or adverse events in the hospital, to improve communication with patients and families, but also between yourselves, your healthcare team, to use medicine safely, use them at the right time and for the right people, preventing falls, preventing other injuries or adverse consequences of care. Now, based on a lot of the input from the Institute of Medicine, the Joint Commission for the Accreditation of Hospitals, these safety goals, each and every one of us who work in epilepsy have to pay attention to this at our own units and think about how we can improve care for people with epilepsy that we treat. A few years ago, the American Epilepsy Society undertook a project to look at patient safety on epilepsy monitoring units and see how we could evaluate whether there was consensus about care practices for monitoring units, how we could develop that consensus and provide some education to those who are involved with epilepsy monitoring units. So the purpose of today's discussion is to talk just about that. What are some of the issues around patient safety for monitoring units? Are there some best practices or consensus on what should be done? And what can we as professionals do to improve patient safety overall? Today, my name's Patty Osborne Schaefer. I'm a nurse specialist at Beth Israel Deaconess Medical Center in Boston, Massachusetts. And I work with the Epilepsy Foundation for the Epilepsy.com. We're going to be joined today by Dr. Nathan Fountain, who is the director of the Comprehensive Epilepsy Center at University of Virginia and chair of the Epilepsy Foundation's Professional Advisory Board. We're also joined by Madonna Pluger, who's a neuroscience clinical nurse specialist at Barrow Neurological Institute at St. Joseph's Hospital and Medical Center. So before I start asking Dr. Fountain and Madonna Pluger some questions about epilepsy monitoring units and safety, I'd like to give a little bit more about the big picture of patient safety. So first of all, how can we improve patient safety? Is it something that's just done by one person? Can I do it in my job or you do it in yours? Well, yes, each and every one of us are important, and we need to do what we think is important to improve patient safety. But it can't be done just by one person. Patient safety means developing a culture where you can keep people safe in your setting or within your organization. It involves patients, it involves families, it involves all levels of healthcare workers, and it involves all levels of administration and support staff within your institution. It can't just be done by one of us. It needs to be a system and an organizational approach to providing care to people within a setting. If we're thinking about an epilepsy monitoring unit, that means the patients and families in the monitoring unit are involved. They're the ones that we're trying to keep safe, right? And we need to understand their needs and their wants and their desires. It means involving the nurses, the patient care technicians, the EEG technicians, your residents, your medical students or nursing students, your epilepsy team, your specialists, to all levels of management and administration that support the care of people. It supports the providers who work there as well as the patients that we're caring for. While we need to have buy-in from all these people, we also need to have commitment. And that commitment is to keeping people safe and providing good quality care. The patient safety also, and a culture of safety, means emphasizing team collaboration and communication. Nothing's going to work if we don't talk amongst each other. Having a culture of safety also means we need to have a culture where we learn from our mistakes, and we shouldn't be blaming each other if something goes wrong, because things do go wrong. And when we're working with people with epilepsy, we have to remember that seizures are unpredictable. We want them to happen when we have someone in a monitoring unit. We never know when they're going to happen, but whenever they do, we need to keep them safe. We don't want to blame each other when something goes wrong, but if something happens, we want to say, what was it that happened? What could we do better? How can we change this to make things even safer and more efficient for all involved? So with that background to developing a culture of safety and thinking about safety on a monitoring unit, I'd like to open this discussion with Dr. Nathan Fountain and Madonna Pluger. So with that background on patient safety, I'd like to turn to our panelists and start kind of getting into some nitty-gritty of patient safety in a monitoring unit. So Dr. Fountain, I'd like to start with you. Granted, many of the professionals listening to this might work in epilepsy monitoring units, but can you give us an overview of what an EMU is and why people would come to one?
Well, in the context of patient safety, we might kind of take a step back and say, even though many people know what it is, specifically, it's an inpatient unit designed for capturing spells and seizures and for monitoring people who have seizures. And that means it's typically hardwired with video cameras to capture the seizures as well as simultaneously recorded EEG by hardwire monitoring. Those technical aspects have traditionally made epilepsy monitoring units geographically separate or isolated, or at least in one spot. And as far as patient safety goes, there's other aspects in that geographic location that are important that make it additional. Some of them are obvious, such as padding on the floor, things like that, rounded edges on furniture. But also, as you mentioned, the culture of safety, but in regards to EMUs, the culture of people having seizures every day. And the reason that people are typically admitted to one is for one of three reasons: either to determine whether or not spells are seizures, to capture seizures for the purpose of localization or pre-surgical evaluation, as we typically call it, or the third reason is someone's having a seizure exacerbation and trying to figure out why and what we can do in the short term as well as the long term to make things better.
So, as you mentioned, an important part on EMU is that a person has seizures. So they could come in because they're having a change in seizures, or because you want to provoke them to have a seizure so you can record them. So I guess I'm going to ask both of you, and I'll start with you, Dr. Fountain. To you, what are the more common risks to patients when you're recording them on an epilepsy monitoring unit? How much is from the risks of seizures versus, withdrawing drugs or other factors?
That's right. They kind of fit into different categories, and the obvious and most common one is simply falling during a seizure. Many people fall during seizures, and they're going to have seizures in the hospital. That's why you've admitted them to the hospital, and beyond that, you might have even tried to do some things to provoke them. So one aspect is many people fall during a seizure, and you have to be prepared for that to avoid injury. The second aspect is that you're right. Not only might they have a seizure as they would at home, But in addition to that, they might have seizures that are more severe or more frequent while they're in the hospital because you've withdrawn their medications to provoke seizures. So you have to be prepared for seizures that are more frequent or severe than at home. More severe is kind of obvious. That also has to do with falling and other aspects that we might talk about later. But in addition, the more frequent seizures, and that means having protocols and observations in place so that if seizures happen too frequently or too many convulsions, for example, there's an intervention automatically in place to address that.
Right. Madonna, I'd like to address to you, as a nurse specialist on the unit, how do you assess patients for their risk of injury? And, what are some of the things that the nurses will be looking for, or what should be done prior to admission so when they get to the unit, you would know what the concerns are?
Patty, I think you highlighted it nicely in your introduction. It's really important to have the communication between the whole team and to know that the patient knows what to expect when they come in and the family, as well as the nurses, to be prepared to know what the patient's history is, what their seizure type is if they do have seizures, or what their spells are like, and to know what the plan is. Depending on the patient presentation, different providers and different team members may have a different plan for that patient. So it's everyone being on the same page.
So, yeah, that's a critical part. You say being on the same page. I work predominantly in an outpatient setting, so I often think about what are some of the individual patient or family specific things that the people on the inpatient unit might not know about, and how can I help them get on the same page? So if the person's got a history of some cognitive difficulties and may have trouble understanding what's going on, it's really critical that the inpatient team understand that and how best to work with them. Or if the person's got an underlying, mood disorder or a chronic pain syndrome, migraines, could something that we do to provoke seizures or withdraw medications, could that exacerbate things for them? So collecting information about your other health problems, other functional issues that a person has, other disabilities, would be pretty critical to try to identify what other risks there are, and then some ways that you can help alleviate that. So, Dr. Fountain, you mentioned before about the importance of observing patients. So how is that typically done on a monitoring unit? And is there kind of like a best practice or a best way of doing that? Or who do you think are the ones that are highest risk that need to be observed?
I'd say the emerging standard is clearly continuous observation. That most often is done by a live stream of the video so that each patient is observed in their room, in their bed, continuously by video recording, and typically that's fed to monitors outside the room in a common monitor watching area. In large monitoring units, which might have 8 or 10 or 12 or more monitors, the patients can be continuously monitored by live eyes, a monitor watcher of some sort watching the monitors, and if someone has a seizure, then alerting the nursing staff for intervention. That's the most common way and really the emerging standard, but having someone in the room to observe it continuously. So for example, in very small monitoring units or in certain circumstances, then having someone actually in the room. The advantage to that's obvious. You could detect things going on. The potential problem with that is that if it's a family member, for instance, they're likely to nod off or be asleep at night and not observing the person having seizures, or might not be trained to actually recognize seizures. There's also intermittent monitoring in which nursing staff or others walking by the monitors might observe. In that case, monitoring detection or seizure detection is relied upon. An automatic seizure detection from a computer, for instance, then alerts the nursing staff is possible, but not entirely reliable. And finally, it's possible to have people unmonitored and just rely on hearing the seizure from afar or a family member nearby. And that's really fallen off as the standard because of the risk of injury or death during a seizure that's not observed.
Right.
So I'd say the best practice is by continuous observation, usually by video monitoring.
Yeah. So that raises an interest through a project with the American Epilepsy Society a few years ago. We did this consensus project to look at what is most typical or what would be best indicated. And the issue of continuous monitoring got the most agreement. But again, the difficulty is, what does continuous mean? But clearly having someone that can be watched at all times. And I think the the take-home point that I had was that anyone who's really having medications withdrawn so that they're at greater risk of change in seizures, or who is considered at high risk for other factors, whether they've got a history of falls or behavioral change or aggression afterwards, or if they have implanted electrodes, were ones that really needed continuous observation. Would you agree with those three?
Yeah, that's definitely true, that for those people, they definitely need continuous observation. You're right that if someone's having seizures at home and then they come into the hospital, they could have them there just like at home, so they're not a particularly increased risk. But I would argue that in that environment, they're in an environment that seizures can be observed. And the emerging standard would still be to observe those people. But you're right, the people at high risk sort of must be observed for standard of care.
Yeah. Madonna, I'd like to direct this to you to kind of, just from the perspective of a nurse, an EEG technologist, an aide, what are some of the strategies that the staff can employ on a unit to help keep patients safe and prevent injury too?
I think the biggest strategy is really knowing about your patient and talking with the family and preparing the patient and the family when they're admitted. Before they're admitted, having that discussion with the outpatient clinic if there is that opportunity, and look at the environment. Make sure that the ongoing discussion is happening between the team, the EEG technologist, the person, if you do have an institution that is observing, having a dedicated observer, the nurse, anyone that is going to interact with that patient, and make sure that you have the patient in the center of the care. Let them know from the very beginning that safety is very important to them. And as we've all talked about today, this is the one place in the hospital where we want seizure events to happen. And we really want to protect them, and we want to make sure that they are in the center from the very beginning.
Good points there. So I would ask now to Dr. Fountain, Madonna just kind of ended there with, this is where we want people to have seizures. So do you have any thoughts to share with our audience about what are some of the safe ways of provoking seizures? Or how would you do it if you're withdrawing drugs?
Withdrawing medications itself is the most common way to provoke seizures, although I would add that many people have seizures provoked by specific factors such as flashing lights, sleep deprivation, stress even. Occasionally there's some unusual things like food, and whatever it is that provokes the seizure, often we'd ask people to do that or be in that situation as long as it's something safe. And I think the important thing is, regardless of the method, which most often be drug withdrawal, that you recognize there may be an exacerbation of seizures. So seizures may be more severe or more frequent, and you have to be prepared to observe that, to notice it, and then to provide an intervention. In many places, drugs are not all withdrawn at once, but instead might be withdrawn gradually, either one drug at a time or over days. Traditionally, in the remote past, we withdrew drugs very slowly over very many days. Now, we withdraw them much more quickly, and in some institutions all at once, although that's not our particular practice. So I think the safe thing to do in considering provoking seizures is to recognize they may be provoked and to then provide ongoing safety interventions. For example, if you think someone's very likely to have a seizure that might be a convulsion when they wouldn't otherwise, even if they would otherwise, you might ask them to be seated or be in bed. We always have patients accompanied by a nurse when they go to the bathroom, and a nurse always stands outside the door since we don't video them in the bathroom. The same thing goes for bathing. So anytime they're not going to be observed by the monitor watcher, that someone's immediately available to notice a seizure and to provide intervention. And also, if they were to have a seizure, they wouldn't injure themselves. So typically that means holding onto their elbow while they're walking across the room or going to the bathroom, or having someone with them. For some people, it might mean putting the bed rails up at night, not as a restraint, but as a safety precaution so that they don't fall out of bed. Occasionally, in the past, we've even put the bed on the floor or padding around the bed when someone actually jumps out of bed during a seizure, but of course that's distinctly uncommon. But the thought process there is very distinct in preventing injury when seizures occur and keeping people safe. And besides the injury we're talking about, there's also two important things we have to talk about, and that's other things that aren't directly traumatic injury from seizures, but the risk of aspiration, which can not just cause pneumonia, but ultimately lead to respiratory compromise and death, of course, or even SUDEP, sudden unexplained death in epilepsy. And there are some things we don't maybe usually think about as safety precautions, because I hope they're universally applied, but they really are. So one is, during a seizure, providing appropriate intervention, which for most people during a convulsive seizure means rolling them onto their side and aspirating with suction any fluids or things they collect in their mouth, particularly if they vomit, so to keep their airway clear. And the second intervention is EKG monitoring and monitoring vital signs after a seizure to make sure that there aren't cardiac or respiratory compromise that could lead to SUDEP or other problems.
Yeah, thank you very much for that, because that raised an important point, is that, your eyes to view a person are critical. The EEG is critical to see if a person's having seizures, but other medical problems could be exacerbated or could occur from a seizure, just as you raised. Or for many people, don't we monitor events and find out that maybe it's a cardiac cause and not an epilepsy seizure? So that cardiac monitoring would be critical. Are there other aspects of or ways of monitoring patients you would recommend?
It really depends on the specific circumstance. So that, of course, in children, they can have a whole variety of spells, some of which are just normal behavior, like in staring spells or inattention. Also, breath-holding spells are usually easily diagnosed. There can be cardiac arrhythmias in adults, as you mentioned. There can also be certain changes in blood chemistry. Some people get hypoglycemic, particularly if they're diabetic, and their insulin's not well regulated, for instance, or occasionally hyperglycemic when they're diabetics and unknown. So certainly that kind of monitoring for those situations which that's suspected is important. Monitoring their vital signs after the seizure is important, and that means respiration, EKG, see if they have a continuously improving level of consciousness. And in those specific circumstances where you do suspect a blood chemistry or glucose change, to monitor that as well.
Great. Madonna, everything that Dr. Fountain is talking about is resource intensive. I mean, and to many of our administrators, they think that people coming with epilepsy are not, don't require a lot of care, because we are essentially bringing them in where they're living with seizures on an outpatient basis, and we're observing for things, and they don't recognize how much needs to be done to get the testing done and the patients in a safe way. So any words of thought that you have for administrators or things, or managers, on how you address the staffing issue and the needs for people with epilepsy?
I think continue to approach it from the awareness point of view. I know at the institution that I work, emucaring.org is a huge resource that we are starting to have all the nurses that work in our epilepsy monitoring unit, as well as the EEG techs and our providers, the epileptologists, view that. So all of the great pointers that Dr. Fountain mentioned that you have commented on today are all there in different modules, and it's really a nice resource. I think also the culture of no blame and really honing in on the fact that there's going to be different regulatory bodies in the future that will be supporting a safe culture in a protected environment, such as the Epilepsy Monitoring Unit, are all benefits. And I think we just need to keep talking, and we need to keep communicating to the administrative bodies.
All right, so before we have to close this out, Madonna just, brought up a critical thing. I was going to ask about, what advice or resources would you tell colleagues about? And you've just raised one about emucaring.org, which is a project from the American Epilepsy Society, where people can get continuing medical education units or continuing nursing or EEG units to learn about patient safety in monitoring units. Dr. Fountain, I want to turn this over to you. What are some of the safety, issues or program resources that could be helpful for physicians? How do you see EMU Caring maybe potentially helpful in that regard?
EMU Caring is clearly the single best resource we have, and I'd encourage everyone to do it. I'd also add that epilepsy centers are now accredited by the National Association of Epilepsy Centers, and each NAC accredited center is very likely to ultimately have to have their staff, in one degree or another, some portion of their staff having taken the EMU course, as we might call it, but that means having participated in the EMU Caring module. So I think that's very important as a single source. The National Association of Epilepsy Centers also is developing some very specific safety modules or protocols, and indeed, being an NAC accredited center now requires having written protocols to address some of these things I've said. And I've already mentioned things you might think about in designing a unit. That's the hard structural things that don't change. like padding on the floor, rounded furniture, having clear sight lines for a camera, having bathrooms that are easily accessible, and if you were to fall in, wouldn't get hurt in. The second thing I mentioned was what to do during a seizure, so seizure first aid and immediately post-dictally for assessments to keep people safe. There's really a third thing I didn't mention that I should that's kind of related to this, and that is that after a seizure, of course, patients sometimes are wild. They might have a post-ictal psychosis in which they're actually delusional. They may become violent. They may become very afraid. And it's very important for the nurses to understand that, because in the vast majority of cases, just directing the patient calmly and not restraining the patient will keep the patient from harming themselves or anyone else the vast majority of time. On the other hand, anytime you try to restrain or confine those patients, it almost invariably leads to a big conflict and sometimes injury. And that I bring that up because that's education of staff. And the physicians often are keenly aware of these certain medical issues I mentioned before, but it's the staff who are there on the ground seeing the seizures every day that need to be educated. So besides the NAEC and EMU Caring, also JACO has some national patient safety goals that are important, and you mentioned some very important things, like we also heard about having the appropriate culture, like a culture of no blame, a culture in which everyone's willing to speak up when there's an issue or problem. There are certain other resources that are emerging. They're more often organized around about epilepsy monitoring unit organization or program organization than they are about safety. So safety is a new vocabulary for us in the epilepsy world, and traditionally we would have just called this epilepsy care. But I think this changed emphasis on safety and also the change to patient-centered care together makes us really concerned about where the rubber meets the road, where the patient's actually having a seizure. And that's, I think, where the efforts have to be directed rather than at an administrative or higher level.
That's a great way to sum this up, is where the rubber meets the road, and that's the patient-centered care is what all of us at these centers are all about. Madonna, I'd like to offer you a chance to say, what advice might you give to patients and families who are considering coming into an epilepsy monitoring unit? Is there something that resource that could be helpful to them, or word of advice or tips that you would offer?
Sure. I think the Epilepsy Foundation, epilepsy.com, the American Epilepsy Society, we all have patient resources available. I would encourage patients and families to actually see about touring the EMU before their admission so they can really get to know the environment. And
I'd like to bring this hangout on patient safety in the epilepsy monitoring unit to a close. I'd like to thank Dr. Fountain and Madonna Pluger for their expertise and willingness to share their thoughts about patient safety with us today. I also want to invite you to explore some other resources that might help you as you refer people to an epilepsy monitoring unit, take care of people there, or just want to learn more about epilepsy. Please visit epilepsy.com and the professional sections where you can learn all about epilepsy, refractory epilepsy, different treatment options, and each month we'll have new features from the Epilepsy Foundation and American Epilepsy Society addressing important topics of concern. I'd also like to encourage you to visit a special educational product on patient safety on epilepsy through the American Epilepsy Society. This can be found right through www.aesnet.org or go directly to www.emucaring.org. This is a special presentation on patient safety, which I think you'll find invaluable. You can also use this to gain continuing education units or continuing medical education units to help in your ongoing education. You can also use the information here to enact change in your units and then evaluate the impact of that changes on improving safety. An example of this is that you can do your own performance improvement project, which is so critical for all of us to keep up to date and show what improvements we make in our care. For more information about comprehensive epilepsy centers, I'd also encourage you to visit the National Association of Epilepsy Centers, where you can find guidelines of what is an epilepsy center and other important information that may be helpful to you. Thank you again for joining us for this hangout, and I look forward to seeing you again.